Hello, everyone. I'd like to welcome you to the ONS webinar series. Tonight, we're going to talk about regenerative medicine, hope or hype. Obviously, a very timely subject. And certainly, I want to present you with all the information we have currently, how we're going about applying some of these regenerative therapies, and how it could potentially benefit you. My name is Demetris Delos. I'm an orthopedic surgeon. I do shoulder and knee surgery, sports medicine, as well as joint replacement surgery. And I've always had a very keen interest in this particular topic. So I'll start off with this slide because we've known for millennia the desire to find that fountain of youth is just so strong. And of course, there were numerous explorers and adventurers who claimed to potentially have found it. But nevertheless, there's that innate desire to try and restore things back to the way they were and to prevent basically the process of senescence. That's the medical term for aging. And we all know what it involves: a declining ability to respond to stress, increased risk of disease. The activity of the various cells in our bodies actually decreases. And of course, there's a gradual deterioration of some of the key structures, organs, and the anatomy that we're going to go over very shortly. So in the orthopedic world, in the musculoskeletal realm, we're concerned with tendons, for instance. And tendons, as you likely know, are attached to muscle on one end and bone on the other. And so the role of the tendon is when the muscle contracts, it pulls on the bone to produce locomotion. And when you look at a healthy tendon under the microscope, what you see are thousands, if not millions, of fibers very neatly aligned in rows. And when you look at a degenerative tendon, instead what you see are these wavy lines, these cells that are completely disorganized, and they're not intricately aligned, and there's spaces between them. And what ends up happening is water seeps into those spaces. And you can actually see this pretty well on an MRI. So we can tell, just looking at the MRI, say of a rotator cuff, whether the tendon appears to be degenerative or whether it appears to be healthy. And of course, the goal is to restore it to a healthy state. Now, the other key structure in orthopedics, or the musculoskeletal system, is of course cartilage. And cartilage is that thin layer of cushion on the end of bones that rub together. So the joint is simply where two or more bones meet and they produce motion. And to provide smooth, friction-free motion, the body has developed that thin layer of cartilage. Now, over time, certainly trauma can contribute, but most cases of arthritis are what we call idiopathic. So no one really understands why. We attribute it to aging, but we're not really sure why it develops. And the problem with arthritis is that when the cartilage wears out, the bone gets exposed, and the bone has nerve endings, and it can produce pain with weight bearing and with motion, unfortunately, as many of us know. And the last thing we will sort of touch upon is ligament injuries. Now, ligament injuries are less common simply due to senescence or aging, although the ligament can deteriorate over time. And this is one arthroscopic image of a ACL on the left, which is relatively healthy, and one which is torn on the right. So the question we want to ask is, can regenerative medicine really halt or reverse these changes? Before we answer that, we'll go over the various therapies that are available. And probably the most prominent one, the one that perhaps you may be most familiar with, is platelet-rich plasma, or PRP. What exactly is it? In essence, it's really just a derivative of blood. And what it involves is the platelet. Now, when you look at this photograph, this is a scanning electron microscope, so it looks at things at a tremendously high resolution. You can see a red blood cell on the left, you see a platelet in the middle, and you see the white blood cell on the right, and the platelet is the smallest one. The value of the platelet is that it is rich in many growth factors and in cell signals that can stimulate healing. And it's a veritable alphabet soup: PDGF, TGF-beta, IGF-1, VEGF. But the things you need to know are that these growth factors and cell signals are what are used to basically promote things like new blood formation, new cartilage formation, bone formation, basically healing. So platelet-rich plasma has been around for 30 or 40 years, or at least it's been used for 30 to 40 years. But in the world of orthopedics, we've only really used it for about 15 to 20 years. And so our data is less robust in general than in other fields, say like the dental world. But we've gotten to know a lot more about PRP over the last 5 to 10 years. How do we make it? Well, for instance, if you were to come to the office, the way we do it is usually one of our nurses will collect blood from a vein, usually the vein in the front of the elbow. We take about 15 cc's. Just to give you some perspective, a can of Coke is 330 cc's. We're taking about 5% of that or less. We put that blood in a tube, and then we spin it in a centrifuge. Now, there are tons of companies that make these centrifuges, but and some of them do 2 spins, some of them do 1, some of them spin it for longer, some of them spin it for shorter. But in essence, what you really need to know is that when we spin the blood, the denser elements will go to the bottom, and the lighter or less dense elements rise to the top. So when you look at that photograph of a vial on the top right, you'll see red blood cells are the heaviest, and they tend to go to the bottom. Plasma is the lightest, and that's the yellowish substance that goes to the top. And then in between are the platelets and white blood cells. And what we want to do is get some of that yellow substance with some of the platelets. And the platelets, again, are what have all the growth factors. So that's what we're really trying to get to. How do we use it in orthopedics? Well, we use it a lot in arthritis or cartilage problems. We use it for tendon problems. We use it for tendinitis. We use it for tendon tears. And we use it in surgery. And we'll sort of touch upon all those various aspects of PRP. Now, we probably, again, use it most commonly for cartilage problems or arthritis. Now, here's an arthroscopic image, basically an image when we put the camera in the knee of someone who has arthritis. And again, you can see the area of exposed bone, and that can be quite painful. So we want to inject the PRP to try and get that person to feel better. And usually we'll do a single injection, although sometimes some protocols call for more, maybe up to 3. But usually it's a single injection. And what we've seen in studies over and over and over the last 5 to 10 years is that PRP does indeed seem to be superior to things like placebo, meaning saline injections, salt water, hyaluronic acid, which are also commonly used, which are sometimes known as the gel shots. And what do we mean by superior? Well, in terms of function and in terms of pain scores, it seems, patients who have gotten these injections seem to do better. And when it comes to PRP, the data for knee arthritis is the most robust. We have many studies that have looked at the topic of knee arthritis and PRP treatment. And in general, what we can say is that people who undergo these injections will notice significant improvement in their symptoms, how they feel, and also in their function for 6 to 12 months. And it's the majority of patients. It's not going to be 95%, but it's probably somewhere between 60 and 80% will notice significant improvement for 6 to 12 months. And the studies do also seem to show that it works better when the arthritis is less severe, which would seem intuitive. However, the one thing I do want to caution you on is that there really is no evidence yet that it can rebuild the cartilage and that it can reverse the arthritis. So again, when we recommend PRP injections for arthritis, it's typically to address the symptoms of arthritis. Unfortunately, the underlying problem, which is the loss of cartilage, is still something that's going to be present. Now, chronic tendinopathy is another area where we will sometimes recommend PRP. And the reason we do that is because, of course, we want to try and stimulate healing. But in a chronic situation in particular, there's very little biologic activity taking place. So when someone has an acute injury, what typically happens? Typically, there's bleeding. And while that bleeding may lead to bruising and pain and other things that we may not want, the blood is what really brings all those reparative cells, those healing cells, to the area of the injury to stimulate the healing. Now, if it's 6 months where you've been having this elbow pain, typically there's very little of that. And so we want to try and reintroduce that biologic activity. And as we talked about when it comes to arthritis, when it comes to the knee in particular, PRP has a lot of data. And when it comes to tennis elbow, there's a lot of data. And the data for PRP in this regard is not only substantial, but it does seem to be consistent, that people with tennis elbow tend to do much better with the PRP injections than with alternative therapies. And some of the things we've tried and still continue to use are steroid injections and needling, where we actually will take a needle and poke tiny holes in the tendon. And again, that's really just to stimulate healing, stimulate biology, stimulate bleeding. The PRP seems to be better for doing that. Now, other things we as orthopedists or musculoskeletal doctors have tried it for is Achilles tendonitis. And unfortunately for that, it does not seem to be as beneficial for whatever reason. One thing I do use PRP for is patellar tendonitis or patellar tendinopathy. And when you look at an MRI, what you'll see, for instance, in this image on the slide, is you will see an area of high signal, or that white spot underneath the kneecap, and that typically indicates a partial tear or an area of tendinosis or tendon breakdown. And there are several studies that have shown that PRP is superior to other things such as physical therapy and needling, although the results tend to be better in the short term, say 6 weeks, 3 months, or 12 weeks. But after an extended period of time, people tend to do just as well with alternative therapies as well. The other thing we've experimented in terms of using PRP for is hamstring injuries, and there are two types of hamstring injuries I might consider it for. One is the chronic hamstring tendinosis, where, say, a runner will have that pain up in the back of the hip or in the gluteal region. And usually that's a chronic partial tear of the hamstring. And if we've tried physical therapy and alternative therapies, we may consider PRP injections. And I've had some, anecdotally at least, good response with that. Sometimes also for people who have chronic strains, which is when you pull the hamstring muscle and you're not getting better, we may consider that. Now, there is some data, even at the NFL level, that suggests perhaps improved return to play, better subjective scores, and lower re-injury rate. But I would caution people that the data for hamstring injuries in PRP is very, very limited. The other thing that PRP has been used for in many studies is rotator cuff tears, and for this, the data is mixed. There was a recent meta-analysis, meaning a collection of various studies that looked at all the studies in aggregate and found that perhaps there are some clinical outcomes that can be better with PRP injections when you're doing cuff repairs, and the re-tear rate may be slightly lower. But again, I would caution people that this is controversial. Now, in ligament injuries, the one area that we have used PRP, and with some success, is with young pitchers. So we know the Tommy John ligament, it's along the inner side of the elbow. And unfortunately, that's a chronic or a very, very frequent source of pain and injury in throwers. And when they have a total ligament injury, usually they'll just undergo the surgery. When it's a partial tear, there is a role for physical therapy and possibly PRP injections. And there is some data to suggest that people can return to sports sooner getting the PRP injection, although again, that's very limited. So what do I like PRP for? I do like it a lot for arthritis. I do think that when we look at our armamentarium of the various injections that are available, whether it's saline shots, which we really don't do, plain lidocaine, cortisone shots, gel shots, I do think PRP is superior. And so for those people, especially with more mild, moderate arthritis, it may be an option if they've undergone the therapy, the anti-inflammatories, et cetera, and still haven't gotten better. I do think for tennis elbow, for people who have not responded to traditional methods of treatment, such as physical therapy, anti-inflammatories, some bracing, we may consider a PRP injection. In people who have had severe rotator cuff tears, I may consider it. And in patellar tendinopathy, that's not getting better, I may consider it. For other things like hamstring, I think it's less frequent. And for Achilles injuries, usually I have not been using it. The other thing I want to mention about PRP, there are some considerations. After the injection, you may actually notice an increase in pain for about a week. And that's because, again, we are injecting a blood product, and blood can be inflammatory, so you need to be aware of that. Usually I will delay rehab for a couple of weeks. In general, the rehab or the approach to treatment after PRP goes in 3 phases. The first few days, you just want to rest the area of injection. After a few days, then you just go back to your normal activities. And then after a couple of weeks, we may start some formal therapy for the area of either injury or disease. And when it comes to the scientific side of things, the medical side of things, the things that we're still struggling with to better understand is, what is the optimal volume? What about the concentration of platelets? These are all very controversial things. What is the role of white blood cells? Because virtually every solution has some element of white blood cells, and it's been argued one way or another that they may or may not be helpful. Which system is best? How many injections? When do we inject? And what's the most effective rehab protocol? So those are a lot of questions when it comes to PRP that we still have not answered, and I just want to make you aware of. Now, when it comes to the fountain of youth, when stem cells were really first discovered, or at least when they were publicized in the late 90s, certainly the scientific community really thought that this could potentially be the fountain of youth. What are stem cells? Well, there are cells in our body that basically have 3 main characteristics. They can multiply, that's one. They are undifferentiated, meaning they have no real defining qualities, although they can develop into virtually any specialized cell. And that's what it means to be pluripotent, or have the potential to develop in numerous different types of cells. And you can acquire stem cells from 2 different areas. One is you can get it from an embryo. And an embryo, as you likely know, is basically the earliest stage of a fetus. A fetus is considered a fetus usually after some elements of development have taken place, usually at about 9 weeks. So the organs have developed, etc. An embryo is before that time. And the other area we get stem cells from is in the adult. We can retrieve it from the bone marrow and from fat. So this is a relatively useful cartoon to better understand. The stem cell is there in the middle, and it can develop into virtually any cell in your body with the right signal and in the right environment. So that's the other thing to remember. Probably the most important concept to understand when it comes to regenerative medicine is that it likely will work best when you have a particular cell that you want to utilize, and you have a signal to that cell so that it can know what to do, and then you house that cell somewhere. So stem cells can turn into cardiac cells or heart cells or gut cells, the enterocytes, or fat cells or red blood cells or chondrocytes, which are cartilage cells or skin cells or neurons. But clearly they must be told why and when to develop into these various cells. And that is still something that obviously scientists are working on to better understand. Now, when we do stem cell therapy, it's about a 20 to 30 minute procedure. It's clearly more invasive than simple PRP injections because unlike PRP where we take it from your vein, we get blood from your vein, here we have to go to the bone marrow or to the fat cells. And usually we do it through the bone marrow. And the easiest spot to get it is actually from the pelvis. And in this case, we put a relatively small needle into the pelvis, collect bone marrow, and then we spin it down in a centrifuge, much like we did with the PRP, to collect the stem cells. Now, there's very limited data when it comes to orthopedic therapies and stem cells. So it does appear to be safe. And again, in the very limited studies that are available worldwide, it does seem to improve pain scores, outcomes, and cause MRI changes. In fact, there was one study that showed maybe it even improved the meniscus after meniscectomy. But these are very, very limited studies with very few patients. And so I wouldn't jump to conclusions just yet. Here's an example or a video that demonstrates the procedure. We make a tiny nick in the skin. You put a small, or you put a needle into the pelvis there, and then you're just taking out some of the bone marrow. Usually we collect about 60 cc's. And in this video, what you're seeing is we're moving around the syringe, moving around the needle to access different areas and collect the bone marrow. And that's kind of it in a nutshell. The needle gets removed, and usually the incision is so small, you either put a tegaderm or you just cover it with a dressing like this. Now, when do I consider using stem cell therapy? I use it with my cartilage surgeries relatively frequently. So if I'm doing a cartilage transplant, where I take cartilage and bone, say from either the bone bank, the tissue bank, sometimes even from the person's own knee, then oftentimes I may consider stem cells or PRP. We may use it for fractures that are not healing, and there is some data to support that. We may use it in chronic muscle or tendon injuries. The problem or the limitations with stem cell therapy are that it is significantly more expensive than, say, PRP or other forms of treatment. It is more invasive. The data is very limited. And much like the PRP data that we have so far, there's very little evidence that it can restore the cartilage, the meniscus, the bone, and all that. So we're still, when it comes to stem cells, we're still trying to figure out all the different permutations and ways in which we can use it to be more effective. Now, the last thing I want to touch upon is amniotic tissue. So we talked about how embryonal stem cells are not utilized here in the US. But the placenta tissue from normal deliveries in which the mother has granted permission to utilize, the placental tissue has the amniotic membrane, which is a thin membrane that lines the inner cavity of the placenta. And this is known to have numerous growth factors, and it's been used for about 100 years for various medical procedures. So the advantage of this is that we have tissue that's readily available. It's often discarded after birth, and it's utilized only with the mother's permission from healthy, normal deliveries. There's no added risk to the fetus or mother, and there's virtually no real ethical concern. And we have access now to growth factors and cell signals from someone that is quite young, who typically has the most activity and the most effective growth factors and cell signals. And the amniotic product can be used as a matrix, as you see here. It can be used in surgery, especially it's been used in nerves and in hand and upper extremity surgeries. It can be used in rotator cuff repairs and other things, foot and ankle. I don't have much experience myself using it, but the amniotic membrane that's in a dehydrated type of product that then is put in a solution is something that we use relatively frequently in the office. And it's a simple way to provide growth factors without the invasiveness of, say, the stem cell procedure. And there is some data, it's very limited, but there was a good study from last year which showed that for knee arthritis, this again is superior to gel shots and saline injections when it comes to patient-reported outcomes and visual and pain scores. So I know that's a lot. And of course, we could discuss this for an entire day, if not longer. There's a lot of controversy when it comes to regenerative medicine, certainly as it's done in orthopedics, because the data is still limited. The studies are still being conducted. But what we can say in conclusion is that PRP definitely has a significant amount of scientific data to support its use for less severe arthritis and for some tendinosis or tendinitis conditions. There's a lot of excitement with stem cells and the amniotic products. They're still being researched, but they do show promise, and there's some limited data to support their use. There's no doubt that biologic treatment of orthopedic problems is the future. And the stuff we do when it comes to surgery, replacing joints and all that, even as an orthopedic surgeon, I'm very hopeful that in the coming, I don't think it's going to be years, but coming decades, we will develop ways to obviate the need to replace joints, say, with metal and plastic, or to do other things that involve surgical management. But ultimately, what it's going to come down to is developing more sophisticated ways of getting those growth factors and stem cells, combining them. So again, it's the cell, it's the messenger or the growth factor, it's the house that all that lives in that needs to be created so that we can make this much more effective. So I appreciate your time. There is going to be a brief survey, and I will look here and answer questions that have been written and suggested. So someone asked, can these shots be given anywhere as in the feet? Now it depends on what it is. PRP can certainly and has been done in various, virtually all around the body. The shots do seem to be safe, and they can be given in the various joints, muscles, tendons of the body with what appears to be little harm. Someone asked, what do the letters PRP stand for? Again, it is for platelet-rich plasma. Plasma is something that's normally in the blood. Platelets are, of course, in the blood as well. They are a component of the blood. And what we do is, again, we centrifuge the blood to separate things out so that we can collect the platelets, because that's where the growth factors are. Another question is, can the amniotic tissue be beneficial to nerve damage from stenosis? There is no evidence that I've seen for its use there, although admittedly, I am not a spine expert, so I would defer to them. But that may be something that perhaps there could be a use for in the future. And certainly I would ask your spine doctor But as far as I've not been exposed to any research regarding that. These various things have, of course, been used in hip arthritis, although knee arthritis, again, is where most of the data is, especially when it comes to PRP. But we suspect that PRP in particular will have benefit in hip arthritis. Now, one of the other questions that certainly I would imagine is on many people's minds is, what about the cost? So unfortunately, even with all the data that PRP has, for instance, insurance still considers it experimental and will not cover it. And so when we look at the various products or therapies we talked about, whether it's amniotic product, whether it's PRP, that powdered amniotic matrix, the viscous, can usually be acquired for less than $1,000. The PRP, depending on where it's done, is usually somewhere around $1,000, although I've heard significantly more. Stem cells are typically, from my understanding of the market, usually somewhere between $4,000 and $10,000. When it comes to our particular practice, the numbers that I've utilized, we have it on the lower end. So, but if you look around, you will see a variety of prices, and certainly when it comes to our practice, the cost is primarily to cover the kits that these products do entail utilizing in order to acquire and utilize the product. Now, another question that someone did ask, and I think it is certainly a fair question, is, are there other discoveries that are taking place that could potentially speed our progress when it comes to biologic and regenerative medicine? And the truth of the matter is, unfortunately, science tends to move relatively slowly because we want to do things in general right, of course. And when it comes to medicine, things need to be peer reviewed, things need to be studied. Ideally, they should be studied in a randomized controlled manner where patients receive the therapy and then another group of patients that are not aware receive either, the two groups of patients either receive the therapy or they receive a placebo or something along those lines, and neither one knows what they got, and neither do the doctors or scientists know what they got. And those types of studies are, one, very costly, and two, they take a lot of time. And certainly when it comes to, say, the vaccine process that's been going on with coronavirus, admittedly, I mean, that certainly has been almost a record pace. And I would imagine if there was enough incentive, something similar, or maybe not so similar, but certainly quicker, could take place when it comes to biologic medicine. But it's going to take a while, unfortunately. Now, another question someone asked is, when do you throw in the towel and get a knee replacement? And I think that is a very good question to ask. So again, the data seems to suggest that these therapies will work better when the disease process is less severe. And that seems somewhat intuitive. When you have, especially, say, take for instance, knee arthritis, typically what will happen is you will develop deformity, stiffness, pain, and swelling over the course of time. When you have undergone extensive non-operative management, when you have developed severe deformity and you're still not getting better, you've tried the other injections, that's probably the time to consider a knee replacement. Usually those patients are, of course, bone on bone when it comes to the degree of arthritis. And for those patients, I'm a little bit less optimistic that platelet-rich plasma can work. Although, again, there's little, there's little evidence that it will be harmful, and it may be something to consider, but I think we need to be cautiously optimistic that it can potentially help. So I think when this disease process gets severe enough where you can't go on living and can't have the quality of life that you would like, that's usually the time to get the knee replacement. So I would like to thank everyone for their time, and certainly please feel free to answer the survey. I hope this was beneficial to you, and I look forward to seeing you in the office if you have a condition that could potentially benefit from these therapies, or if you have some of the other conditions that I treat, and certainly you can see any of our doctors for the other conditions as well. Have a great night.